Thanks very much, Carl. It's a delight to be back in Oxford, though the weather's not been so good as usual. So I thought after Rustam's talk we should just go to lunch, actually. Pretty hard act to follow, but I'm told lunch isn't ready, so I'll try and entertain you between now and then and extend what Rustam's been saying for neurological lesions and vascular lesions to the rest of medicine, because I think I've come to recognise very slowly, far too slowly in fact, that the whole problem of overdiagnosis and overtreatment is probably the biggest threat to the sustainability of medicine. I didn't believe that when I was at the Centre for Evidence-Based Medicine. I thought it was actually the underuse of good evidence that we had from controlled trials. But actually I think it's this overuse that is a big problem, and it's the overdiagnosis. So I was taught about it as a medical student with medical nemesis. Ray Moynihan, who's the person that's really convinced me about this, wrote a book in the 1990s called Too Much Medicine, and a series on the ABC in Australia. The BMJ has been supporting this for a long time and is a long-term promoter of the idea of too much medicine, that we need a balance. And Gil Welsh and Steve Willerson and Lisa Schwartz have been doing a lot of great work at Dartmouth as well. So I might begin with a Leunig cartoon. Leunig is an Australian cartoonist who just does some things that just in a few words or capture the essence of these problems. So this one is for psychiatry, and I think psychiatry has had a particular problem because you don't have a gold standard in psychiatry. And there's actually been a campaign by Alan Francis, who chaired the DSM-4, which is the sort of Bible for the categorisations in psychiatry. He had actually retired, and he came out of retirement because he was so shocked by what was happening in DSM-5 and ended up writing this book called Saving Normal, because he thinks that the overdiagnosis in psychiatry, which he saw as a problem arising out of DSM-4, has been greatly extended with DSM-5 and has joined this campaign against overdiagnosis in medicine, but he recognises that it's not just psychiatry. So I'm going to continue the theme of our previous two speakers, but I'm going to really focus on this thing of overdiagnosis and how it's related to the guidelines and what we do in clinical practice. And I'll touch on overtreatment and overdetection as well in that. I'm going to give you three classes of overdiagnosis. One is overdetection, and this is an example in India of trying to detect more thyroid cancer. Second is over-definition, that the guideline panels have often extended the definitions of disease in order to, I would think, in some ways create a larger market. And then there's the problem of medicalization, which was what Ivan Illich had talked about when I was a medical student. Okay, over-detection. This is the example I often use because I think it's the most striking. We often hear about over-detection of cancer with regards to breast cancer and prostate cancer, where there have been screening programs. But no one expects that that's happened with thyroid cancer. But in fact, this is figures from Australia. This is the mortality down the bottom here, which has been slowly declining a little bit as treatments have gotten better. But thyroid cancer incidence has increased by about threefold over the last 25 years. Is that the radiation, the hole in the ozone layer or something that's been causing this? No, it's probably due to overdetection. And we're not sure of all of the roots to this, but one of them at least is when an ultrasonographer is looking at the carotid, for example, or some other structure in the neck, and they think, well, while I'm there, I'll just have a little look at the thyroid as well. They discover a lump there, and so they have to report that, and there's a reported lump, and then they have to biopsy it, and then the whole cascade of investigation continues. This is not Australia alone. This has been documented in the US, in many countries in Europe, but the world record holders at the moment is South Korea, who've had a 15-fold increase in thyroid cancer. 15-fold. Again, like the US, like Australia, like Europe, no change in mortality. So most of this must be over-detection. We can't completely prove that, but this sounds, the circumstantial evidence is that this must be over-detection. And interestingly, I was talking to an ultrasonographer about this, and she said two interesting things. One is that you could recognise an ultrasonographer because of the little scar on their neck. And the second was that in her institution they'd actually been forbidden to look at the thyroid when they were looking at something else unless it was explicitly on the request form because of this problem of incidental omas, and that had reduced the number of incidental omas occurring. Now, one of the problems is just the way we label cancers, and this has been a problem in breast cancer, particularly with ductal carcinoma in situ, DCIS. Recently there's been a relabeling suggested, changing the name from encapsulated follicular variant of papillary thyroid carcinoma to non-invasive follicular thyroid neoplasm with papillary-like nuclear features, which sounds so much less harmful and but more benign, doesn't it? Okay, at least it doesn't have the word cancer in there. You've got to recognise that neoplasm is that. And that would only affect about 1 in 6 of the cases though. So I think relabelling is actually an important thing to do, but it's clearly not going to solve most of the problem that we're talking about here. And the problem really, and this is the most beautiful diagram of it, is that there's such a variation in the behaviour of tumours, and a lot of it we can't predict. And so you get these fast-growing tumours, the slow-growing tumours, the very slow tortoises here, who may grow so slowly that they never affect a person in their lifetime, and that they're even non-progressive. And in fact, I think the diagram's slightly incomplete because there are some tumours that regress as well. Neuroblastoma in kids being a very good example of that. And these are the ones where you get the overdiagnosis occurring. And the problem is the proportions of those. How much of the ones we're detecting in thyroid cancer, it must be quite high. But how much in all the different cancers are we detecting in terms of overdiagnosis? So these are some rough figures, but I must emphasise that we haven't even agreed yet on exactly how to estimate the amount of overdiagnosis, because it's actually a very difficult thing to do. But roughly speaking, thyroid cancer has had this 3-fold increase, breast cancer about a 1.4, renal cancer a 2-fold increase, in mostly incidentally detected renal cancers, prostate cancer about a 2-fold, probably more increase depending upon the degree of penetration of PSA. And 2 of those have been by sort of deliberate screening, but 2 of them have really been just incidental findings increasing over time. None of these 4 probably had real changes in terms of the actual incidence occurring, or at least it doesn't explain most of the increases. Now, in terms of over-treatment, which we're talking about as well, you have to think that that over-detection actually leads to over-treatment, that people with those incidental thyroid tumours, there's starting to be a little bit more watch and wait, but a lot of them have actually ended up with having thyroid surgery. That leads to not only the surgery, but the complications of surgery, the treatment. You'll usually need to take thyroid replacement therapy for the rest of your life, go along to visits, etc. So all of those things will be occurring as a result of it. And as Margaret McCarthy says, that means that the people who are formerly well are in a sense being over-treated, and that changes the cues and access for the people who really have a true illness as well. So this is the paradox that she talks about. So that's neurology, cancer. This is probably occurring in almost every area of medicine though. So I'm working with some people in musculoskeletal medicine, a rheumatologist and physiotherapist at the moment in the areas of musculoskeletal. And this is some interesting figures we put together for a grant proposal. It's a summary of some findings that you would get in 50 to 60-year-olds, that's people slightly younger than me, who are asymptomatic. These are people who had no symptoms but had ultrasound of the shoulder, you find a rotator cuff tear in about 13%. If you do an MRI of the spine, you find a disc bulge in 78% and disc protrusion in 28%. MRI of the knee, 20% have meniscal damage, 84% have any abnormality. So in fact, if you don't have something on imaging, you're probably abnormal. The normal range is to have at least one lesion. We should be worried if you come back with a completely clear one. So what can we do about that? Well, one is to actually report this, and it may be an age-specific band. So going back to that study that I mentioned, this is the rate in different age bands of disc bulges and disc protrusions occurring. In asymptomatic, I emphasise, people with an MRI. Okay. So one thing you might want to do is to report that in the report. We don't report in imaging study. When you get an imaging report, you just get the lesions reported. No one tells you the normative information of how common these are in asymptomatic people. And maybe that would help. So this is one possible format of it. Here's the comment and here are the findings put in the context of how much abnormalities you'll see on a typical spinal image. And a trial of this has been done, a randomised trial comparing having that sort of a statement inserted, this is it down here, it's shrunken so you can't read it, with the non-statement group. And it seems to have made some difference, but this is a pilot study I think that needs to be replicated. In particular, narcotic prescriptions were drastically decreased in the group that had the statement. And some of the other things look a bit better, but it's not definitive yet. But I think it's the sort of direction that we need to go in, is finding ways to communicate this problem of the incidental omas in a standardised way. And as part of the grant that we're doing, we want to replicate those sorts of studies for several joints. So the problem of too much testing, I think, is summed up by this statement by Clifton Meador, who said, "A well person is someone who hasn't been completely worked up." Okay. So that's our tests, our imaging tests in a sense, and all our tests in fact getting better and being able to detect things that probably won't harm people. The other thing is, whatever the test is, that we can also expand the definition. So again, this comes from Gil Welch's and Schwartz and Woolishan, is looking at the changes in the American Diabetes Association guidelines and how many people that affected when there was a change in 2003. And even though it seems to be a very small change in absolute terms, because of its position on the normal curve, it actually influenced a very large number of people to be diagnosed. And the little aeroplane up here is to remind you that this can have all sorts of influences besides what you think of as the immediate medical ones. A colleague of mine who's an airline pilot nearly lost his licence because of this he fell into the new definition. Right? And so for some people it can actually have quite serious occupational implications, because diabetes, that means problems with eyes and all sorts of things. You can't be an airline pilot. So this changes the number of airline pilots that you would now kick out by doing this. These are the age-specific prevalences with the new one, which obviously rises with age. For the over 65s, it's about nearly 27%. For some people though, that's still not large enough, so you could always create categories like pre-diabetes, which is going to have 86 million Americans classified as having pre-diabetes. This actually comes from work by the CDC in the United States promoting pre-diabetes. And if that's not large enough, of course, we could always create pre-diabetes, which all of us would have. Okay, so this sort of tussle over the definitions is actually very important, because it can have substantial changes to the number of people affected. And as I showed you on that normal curve, it doesn't need to look like a very large, in numeric terms, change, but can have huge changes to the number of people affected. So another example of this is gestational diabetes, where this new group, the IADPSG, had suggested, because of the slightly increased risk, that they should change the definition of gestational diabetes. Well, compared with the old definition that WHO had, which had a 6% prevalence, this would create something like an 18% prevalence, a threefold increase in the number having gestational diabetes, and the costs in the US had been calculated at $2.5 billion. The NIH held a consensus conference on this in 2013 and concluded that there was no evidence that the treatment of these new cases actually improved outcomes. It was clear that though it's slightly higher risk of having the complications of diabetes in pregnancy, but that treatment couldn't necessarily change those, or that the benefits outweighed the harms of treatments, a bit like Rustom's neurological lesions. That you've got to weigh up the two things, and you don't know what the balance is going to be until you've actually done the trials, which are now going on. So we had a look, this is Ray Moynihan's work and part of his PhD thesis, at how common this change of definition is. And a lot of these changes appear to come from guideline panels. So we looked at 14 common conditions with 16 publications in all, and found that in 10 cases they were widened. Only one ever narrowed the definition. And that was because a lot of preceding things had widened the definition. They finally thought, oh, we better step it back a little bit because there's evidence of harm. But mostly people seem to widen the definition of disease, and by three methods. One is creating pre-diseases, one is lowering thresholds, or one is changing to a new diagnostic method. We're going to use a better imaging technique, for example. None of them really had a rigorous assessment of the potential harms involved in changing these definitions. And there was a large number of people who were conflicted, 75%, 12 out of the 16 chairs of the guideline panels, a little like Rustam's, actually had conflicts of interest. We think the chairs in particular, as Jin has now suggested, should have no conflicts of interest. Some panel members might, but the chair in particular should not. So one of the conclusions we came up with is that research and policy attention needs to be directed at designing new processes for reviewing disease definitions free of these conflicts and informed by rigorous analysis of the benefits and the harms. To give you an example of the sort of thing people stated as harms is the main negative consequence of raising the age of onset is an increase in the prevalence. This is for ADHD. But no further sort of nuanced discussion of what those harms might be. It's just, oh, it could increase the prevalence, but didn't quantify it and didn't actually talk about the other potential harms. The one for Alzheimer's said ethical and practical implications of a diagnosis of Alzheimer's disease at preclinical stages needs to be studied. And I've got some sympathy here because, in fact, I think we do need the categories that the group talked about for doing research in those areas. But a problem has been people have taken those new classifications and started to use them clinically. I think particularly in this country, there's been a push to diagnose the pre-Alzheimer's states of minimal cognitive impairment and pre-Alzheimer's. So at the moment there's a GIN working group looking at how to set up some of these rules to say what guideline panels, how they should be constituted and what rules they should look at for changing definitions. Okay, I'm going to finish briefly with medicalization. This is a sign that was apparently up in a Boston subway. Some of you may have heard of body dysmorphic disorder where you don't like your appearance and you misperceive it, but apparently you can also have it by proxy. That's where you find you're really psychiatrically disturbed by somebody else's appearance. So it's fortunately not in the DSM-5. But there are things in the DSM-5, and as I mentioned, Alan Francis, who is the chair of the DSM-4, has been writing a panel in Psychology Today about how to overcome the worst things in the overdiagnosis that's occurring in psychiatry. And this is one that he had about Keith Connors. I don't know if any of you know the Connors rating scale, which is the standard thing that's used for defining ADHD and measuring its activity. And he now regrets its misuse. And it was based on some data that he saw that said that clinically only about 1 to 2% actually qualify for ADHD, but the actual percentage of kids getting treated in the US is 15% by the age of 18 years. And there's this disconnect then between what he felt was actually an appropriate diagnosis, and there probably are kids that truly deserve having the current treatments, and what was currently going on. And there's a huge cost to that as well. And so Connors said, "My review suddenly flipped my perception. I felt and announced to stunned colleagues that overdiagnosis of ADHD was an epidemic of tragic proportions." That varies hugely by country, of course. In France, this is still a pretty rare diagnosis, but in other countries, they're closer to the US end of the spectrum. And it's not just psychiatry that has this medicalisation problem. Just before I left to come here, this was an ad that was in the Sydney Morning Herald. Hope has arrived for men over 30 with low testosterone. This is great because apparently I look like this currently on the left, but if I go and see this chap here, I can actually look like this. I'm really, really tempted, but unfortunately he didn't give any references to the systematic reviews that I needed to know whether low T was actually a thing that needed to be treated and whether testosterone was actually going to help or not. When you look at those reviews, you actually find very little evidence that will help any of the things that are claimed of in this ad as well. And it seems to me another medicalisation of ageing is that testosterone does go down as you age, as do many other things, including my hearing and my sight, but that's just a normal part of ageing. Okay, so why does overdiagnosis matter? I just love this quote from Margaret McCartney in her book on the patient paradox. "Too much testing of well people and not enough care for the sick worsens health inequalities and drains professionalism, harming both those who need treatment and those who don't." We need to take care of this problem both for the sick and the well, because we're harming the well and we're harming the sick whose resources are being consumed by this over-treatment. So I'm going to summarise this with these three types of over-detection. One is that we have too many good imaging techniques now, or other tests which we use in too frequently and reuse too frequently as well. We also have problems with over-definition, largely because of the guideline panels, and we should stop the conflicts of interest in those guideline panels and get them to think more rigorously about benefits and harms. And medicalisation, I think, is an even greater area where, as Rustam had mentioned with his Preventicum group, that it's such a money-making area for people to promote a disease as a way of selling preventions and treatments that actually aren't going to make us any better. In fact, may well harm us. Thank you very much.